Let's go ahead and move on to the last talk of the afternoon, and then we will go onto the panel. So I'd like to welcome Dr. Seth Guikema, who's a professor in the Departments of Industrial and Operations Engineering and Civil and Environmental Engineering at the University of Michigan. The research in Professor Guikema's research group is focused on issues of resilience, risk, sustainability, and equity, particularly in areas prone to significant natural hazards. Methodologically, the group's research is grounded in and advances risk analysis, predictive machine learning, agent-based modeling, stochastic simulation, decision analysis. Dr. Guikema has been tackling questions around university classrooms and COVID-19 spread with a focus on the College of Engineering. So I'm looking forward to hearing more about that. Please welcome Dr. Guikema.
Thank you, Emily. And this is joint work with Jim Bajan, Tessa Swanson, and Christopher Schmansky. Jim and I are the co-founders of the new risk analysis, or the Center for Risk Analysis Informed Decision Engineering at the University of Michigan. And Tessa is the PhD student who has done a lot of this work. So we all know that's where the real effort has been. And then Christopher is a master's student that has been working with us. So what have we been working on? Well, we have been working to help support the College of Engineering in terms of planning for fall. So the stated goal as we came into this was to have a fall 2021 semester that looks closer to 2019 than to 2020, while keeping risks associated with COVID-19 to an acceptable level. So then our goal as the risk analyst working on this is to develop a risk analysis and communication method to help support that COE decision making. So look at different types of options and look at how they affect risk and look at their costs. And we're looking at the educational component of this, so classrooms. We're not looking more broadly than that at this point. Okay, so I am a risk analyst. That is my area of expertise. So let's talk a little bit about what risk is. When we think about risk, we're really trying to answer kind of some key questions. Essentially, what can happen? So what are the possible outcomes that we're looking at? How likely are these outcomes? And what's the knowledge base underlying the assessment of that likelihood? So how likely is it? Then what are the consequences, or how bad is it? And then what can we do to help manage that risk? And in some cases, the decision is we accept the risk as it is, and there's a residual risk. So that risk includes both the likelihood of the outcome and the consequences of the outcome, and then the associated uncertainty that comes together with that. And when we think about managing risk in a context like COVID, we have to balance a lot of different competing goals, where we as the decision makers, the dean and the other university decision makers, we have to balance health outcomes, educational outcomes, mental health, university financial outcomes, research productivity, university reputation, student outcomes, a whole host of different things. So when we think about risk management, we have to think holistically about all these different outcomes that might happen in this case. Okay, so the general principles guiding our analysis as we went into this, and I should say this started about 6 or 7 weeks ago. So this has been a really intense effort to get us to this point because we have decisions that have to be made for fall semester soon. When we think about risk, it's about more than transmissions and infections. We have to think about some measure of the severity of the health outcomes for those infected individuals in the institution and the public. We can't just stop at infections, or we haven't really fully addressed risk. There are 3 main modes of transmission that are of concern: fomites, droplets, and aerosols. Of these, fomites are not really a major concern at this point. So fomites is those surfaces. So this is why everybody was wiping their groceries early on in the pandemic. And then we've got droplets and aerosols. And like Jesse said earlier, there's really a gradation of sizes. It's not a strict droplet versus aerosol, and we're not going to get into that debate. But aerosols are a substantial transmission pathway. And like Jesse said, it took a long time for CDC and some other organizations to get there. But aerosols are a major focus of what we're doing, and we're working very closely with Jesse's team on that. We cannot guarantee zero transmission within facilities. That's not an achievable goal unless we're just going to close everything down. And there is considerable uncertainty in transmission, and there will be when we have to make decisions for fall 2021. There are also risks that we have decided to accept that we might be able to use as comparisons. Okay, so that is kind of the underlying principle. One of the major principles in risk analysis is defense in depth. You don't put all your eggs in one basket is a different way to say it, right? So we think about different ways of managing that risk. And we often think about this as the Swiss cheese model, right? So you've got different layers of cheese, and each of those is a defensive mechanism. If something can get through holes through all the layers, then we haven't blocked that risk, right? So we can think about layers to try to reduce the likelihood of infection, affected individuals being in classrooms. So testing, for example. We can think about layers to defend against fomites. surface cleaning. We can think about layers to try to deal with droplets. So masks work really well for droplets. We can think about layers to try and deal with aerosols. So looking at air exchange, filtration, things like that. If we still have residual risk that we need to do something about for selected individuals, we can think about individual level protection, things like the PAPR helmets and directed airflow and things like that. And then layer 6 is vaccines, which we'll talk more about vaccines as we go here. So qualitatively, we took a look at these different types of mitigation options and said, okay, well, what's kind of the effectiveness within these different pathways, right? So we can think about fomites, we can think about aerosols from the bulk air in the room, or aerosols from the nearby, kind of the plume effect. We can think about droplets. We can think about both air nearby and not. And we can think about these different types of mitigation options, what their strengths are and what their vulnerabilities are. I'm not going to go through all of them, but vaccines. So vaccines work well for all of them, but its vulnerabilities are potentially new strains that may or may not escape, uptake in the population, and the permanence of the protection. Whereas if you look at like in-room filtration or UVC, that's really about aerosols. It doesn't help with a lot of the other stuff, but it applies to not just this virus, but flu and everything else that we might see in the future. So there's also some trade-offs between the specificity to this particular virus and broader applicability over the long run. Okay, so let's jump into our risk modeling structure. So there's 3 core components to a risk model like this. So the first is exposure. What are people in those classrooms exposed to over time? A dose response, so how do we convert exposure into a probability of infection? And then a health outcome. So given infected, what is the health outcome for each of those individuals? So what do? Well, we simulate a full semester 1 day at a time. We build that up, so we simulate all the classes over the operation of a semester of the College of Engineering, and we track infected individuals, and we look at health outcomes. Before I jump into that in more detail, all models have assumptions. All models are wrong. Some of them are useful. So our goal is to be, we know we're not going to be perfect, but we want to make this a useful model. So let's talk about our assumptions. We're ignoring droplets. So implicitly, we're assuming masks. So we're going to show you a non-masked scenario, but we're assuming no droplet. We're assuming no fomites. So we don't look at those. Right now, we are using a well-mixed room model. That is, like Jesse talked about in his talk, that the concentration is the same throughout the room. And like Jesse talked about, this is not a great assumption. On average, maybe it's okay, and this is why we're working closely with Jesse's team, so we can try to get that correction to this well-mixed room, so we can look at the actual probability density function of exposure. Right now, we assume that vaccines work perfectly. That is, there are no infections of infected or vaccinated individuals, and they don't transmit it. We have infections occurring outside the classroom as exogenous to the model. That is, we have an outside random infection rate that we can change. Right now, we assume 0.2% per day, which was based on the rate that was being detected at the University of Michigan when we first did this model. We assume a 2-day lag between someone becoming infected and becoming infectious. Can change that. Right now, we're running with a current testing program from U of M, so every student is tested once every 7 days. We currently fix a vaccination status up front. We can change that. And we don't have the actual fall 2019 schedule. So what we're doing is generating a feasible course schedule for all approximately 10,000 students in the College of Engineering. Okay, so this dose response function is a pretty critical part of this. So what this gives is a probability of an infection as a function of some cumulative dose D. There's multiple forms, but 2 of the common forms are an exponential model and a beta Poisson model. But there's a challenge in that we don't actually know a dose response function for SARS-CoV-2. There is not one published. People are using proxies from CoV-1 and coronavirus 229E, and that 229E one is a popular one that people use. There's a lot of uncertainty in what this dose response function is. And we don't really know it. So be cautious when you see results that pick one parameter and use it. So what options do we have for addressing this? 1, we can pretend it doesn't exist. We choose a single parameter value, state it, and provide the results only for that value. And there's an awful lot of this in the literature. 2, we could try to assign a probability distribution over that parameter value and then sample from that as well, and then present probability distributions for results that include that uncertainty. So this sounds great, but how do we even assign a probability distribution to those parameter values? 3, we could choose bounding values and do sensitivity analysis to the influence of that parameter. And you're going to see some results that look like this. And then 4, we could take that to the next step, which is to use p-boxes or a hierarchical probability model to more completely represent that deeper uncertainty about the dose response function. And we're working on that as well. Okay, so now let's talk about our model. So this is a stochastic simulation model. So if we start at a single class period, right? So a meeting of one class, my class meets on Tuesday and Thursday. So pick one of those days, Tuesday, 10:30 to 12. Okay, well, we've got, first we estimate the concentration in the room, given that there's an external, okay, well, who's infected in the room? For that concentration, then we estimate the probability of infection for each student in that room using the dose response function. Then, okay, that's one class. Now we build up to the whole day. So now we simulate all the classes that meet on that day in the College of Engineering. Then we do this for all of the days across the entire semester. And we estimate then which students are infected across that entire semester. And once you're infected at one point in the semester, we assume you cannot be infected again. Okay, so that gives us one replication of the semester. We then do this a large number of times so we can get stochastic convergence. Once we've done that, then we say, okay, after that, now let's go back and we know who is infected. Now let's simulate their health outcomes. Did they end up in the hospital? Did they end up in the ICU? Did they end up dying? So this is the stochastic simulation model that we're using. We're then looking at different types of scenarios, and these are room level scenarios, right? And there's some interventions you can do. The obvious one is masking. Do we use masks or not? There's a lot of uncertainty and disagreement about how effective masks are. The studies seem to be pointing towards like a maybe 30 to 50% effective as actually worn. The material itself is effective, but when you look at how people wear them, there's lots of issues there. So right now we put in 40% effective masks. You can also think about in-room interventions like in-room HEPA filters or in-room UVC. Probably everybody knows what a HEPA filter is. UVC is basically upshining UVC that sterilizes the air that flows through it. There's one particular implementation where you put it on the top of a fan. So you're also mixing the air, driving it closer to maybe well mixed, possibly. Jesse's helping us on that one. But also pushing it through that UV field, and that can really decrease the viral concentrations. Okay, so I'm going to show some results now. So these are 3 scenarios. So scenario A is full density, College of Engineering, full semester, no masks, no UVC. And this is 10,000 replication or 1,000 replications of infections. And these are 2 different parameters of a exponential dose response. So we have a low transmissibility version and a high transmissibility version. And these are from the literature, and they bound SARS-CoV-1. So if we look at the upper left and look at the number of infections, you can see that there's quite a bit of difference with these 2 parameters of transmission. As we start to implement intervention measures, so the middle column is masking, and then the right column is masking plus UVC. So as we add intervention, we shift the distributions to the left, and we also make them more narrow. We're reducing that uncertainty on the infections. But we can't really stop just at infections. What are the actual health outcomes? So then we do another layer of simulation of health outcomes given infections. And here I've sorted this a little bit differently. Kind of that yellowish color is the high transmissibility parameter value, and the blue color is the low transmissibility. And then the sorting is no interventions, then mask, and UV. And in all of these simulations, we're assuming that 90% of these students are vaccinated. We're assuming an upfront infection rate that 1% of students are infected at the start of the semester. 0.2% of students are infected outside the classroom each day and injected into the classroom. We use the current once-a-week testing program. So if they test positive, they are removed from the circulating population. We assume that 40% of infected individuals are asymptomatic. They're not caught until they're tested. The 60% remove themselves as soon as they have symptoms. We assume a 2-day lag between becoming infected and becoming infectious, and that we assume that vaccines work perfectly at preventing infection and preventing transmission. Okay, so let's take a little bit of time to look at these. So this is entire College of Engineering, 10,000 students. So 1,000 of them are then not vaccinated. Well, the probability of 1 or more death, if we have no mitigation and a high transmissibility side of the virus, is 0.02. Right, and then as we add masks, we drop that by an order of magnitude, and as we add UV, we drop that by another order of magnitude. If instead we look at the low transmissibility one down below, we still see an order of magnitude drop roughly, with each additional, from masking and the masking to UV, but the probabilities are lower. So there is some chance that there's going to be a death. It's a relatively small chance in most cases. So let's put this in context. Let's take those 1,000 unvaccinated students and ask what else they might do during a semester, right? So the one on the bottom at the chart, or the one on the right of the graph, is what if we take those 1,000 students and assume that each one of them bikes 100 miles during the semester? So say they bike 10 miles a day for a certain number of weeks, right? So what's their probability of death? Well, we can look at the average bicycle death rate, and we can see that that's pretty high. That's 0.03. Well, what if they each of those 1,000 students drive 1,000 miles during that semester on using the Michigan average highway fatal accident rate? Well, that's 0.013. And then we can look at kind of the rank ordering of this and say, well, relative to other risks that students may face, how does this COVID risk compare? And with the exception of that first blue bar, which is no masks, no UV, and really high transmissibility, most of them are smaller than these kind of common everyday risks that students are facing. The one exception is the flying one, right? Because flying is pretty safe. So if we take the 737, 300, 400, 500, so not the 737 MAX, and each of those 1,000 students takes a round trip sometime during the semester, we get 0.0003. So that one is smaller. So we can start to say, look at these comparisons and ask, okay, well, how do these risks compare to these others? These are community-wide risks. This is not individual risk at this point. We're working towards that. This is total across the College of Engineering. What's the probability that we have a death from each of these things? There are some uncertainties around this, though, right? We have uncertainties about the prevalence of COVID within the community and what that will look like this fall. We also don't know the status of the vaccination program. We don't know what the penetration in the student and faculty communities will be. We don't know what the effectiveness against any variants that we might have this fall will be. There has not been a clear decision on where masks will be required and what type will be required, and that makes a distance. We don't have a decision on spacing. Is this full density or some sort of reduced density? And as Jesse, I think, said during his talk, reduced density reduces the probability that you have an infected individual in the room, and it reduces the number of potentially susceptible people there. What it does to the internal dynamics of transmission in the room is, I think, more uncertain. And we don't know to what degree we're going to rely on defense in depth versus put our eggs in the vaccination basket. And kind of layered on top of all of this is a real need for timely and transparent communication of what these plans look like. So I'm going to stop there, and I think I'm the last speaker, so I think we can go into questions. Emily?
Absolutely. So you've gotten one question from the audience, and so I'm going to pose that to you now, and then we'll switch over to the panel and have a broader conversation. But, and I've seen this as a theme in some of the questions in the other presentations as well, this idea of health outcomes being focused on recovery, hospitalization, ICU, or death, and not looking at long-term outcomes, disability, other sort of measures of burden. How do you think about that in your model? Are you going to do any revisions on that?
Yes, this is one that we have been talking about and trying to find information on. At this point, it's really hard to find good information on long-term COVID, right? This is something we would like to be able to model, but we have not been able to find the type of data we need to be able to do that in a defensible way. So right now we're modeling what's your maximum outcome, infected, hospital, ICU, or death, and not modeling long-term COVID, which is, I think, a really important part of this and a really important caveat to give.
Excellent. Well, I'm sure there'll be more discussion about that in a moment.